Thank you so much, Andrew. That's quite the introduction. I usually just put Smith on my name tag and tell people I'm the janitor. So it's a bit more pomp and circumstance than I'm used to. Without further ado, and thank you so much, everyone, for having me and for coming out. Really appreciate you tuning in. Without further ado, let's dive in. This is going to be better medicine in bad places, optimizing trauma outcomes in austere, humanitarian, and disaster settings. Most important things on this slide are no conflicts of interest. I do quite frequently get donations of equipment and supplies from various manufacturers and distributors, but I've tried very hard not to name anyone by name in this. And if I do inadvertently mention a particular product or anything, we'll just immediately discuss how wonderful their competitors are, because in our practice environments that we're discussing here, the right answer is the one that works. Next most important thing on this slide, of course, is my email address at the bottom. If you do have questions, comments, concerns after the presentation. We are going to fly. This is a lot of material to cover in a little bit of time. It's a topic with a lot of breadth, so we're not going to do too much depth. Key things I want you to think about: be a clinician, not a technician. The number one thing that messes people up in humanitarian settings is getting stuck on a static picture of a dynamic situation, failing to pre-game the situation. Think about what they may need. Where are the gaps? Again, I want you to think like a 4-year-old engineer. As we go through this, I want you to always ask yourself why. Keep your eye on the prize in terms of patient care, but also don't lose track of the big picture in terms of sustainability and systems development. A couple of favorite quotes: education is not the learning of the facts, but training the mind to think. That's a very appropriate sentiment for a lecture like this, where, again, the facts can be very fluid depending on the situation you find yourself in. Right? If you only learn to cook using a recipe and you don't have a particular ingredient, that can kind of leave you high and dry. Whereas if you learn underlying principles, you remain infinitely adaptable. Again, when it comes to education, the most important thing is appetite. Stay humble and hungry. Right? A full mongoose is a slow mongoose. When it comes to medical mission work and patient care in general, remember what General Patton said: if everyone's thinking alike, someone's not thinking. Key to being adaptable is remember that there's multiple ways to do things. Cannot emphasize enough, begin with the end in mind. Failing to plan is planning to fail. This is not your level 1 trauma center where you have every possible resource under the sun and it's been planned out from beginning to end. You need to anticipate gaps in the systems. One of the most common things that we run into when we talk about humanitarian and disaster medicine is folks not seeing the trees for the forest, or not seeing the forest for the trees, rather. They're very familiar with their specific skill set, but tend to overlook things in big picture mission planning. Some specific examples of that, again, it's multivariate, but a few examples. Where's your power coming from? What are your fuel supplies? Have you thought about solar? Have you thought about what type of power you have? Is it a clean supply? Is it a dirty supply? One very important real-time example of this right now is that numerous medical missions in Haiti are having to cancel, not only because of the unrest, but because of the lack of fuel. Other things to think about alternate ways to do things. Another common issue besides power supply is medical gas supply. So when you think about, for example, how are you going to deliver oxygen to your patients? Think about simple designs on vents with internal turbines that don't necessarily require an external gas supply. Think about using oxygen concentrators. Don't forget to take into account your sterilization. Again, not your level 1 trauma center. Another example of long-range thinking that I include in here, just for your consideration, blast injuries. Don't just think about the injury at the point of care that you're tending to, but think about the sequelae. Blast injuries are a very common example of this when we think about diffuse axonal injury and traumatic brain injury when we think about blast lung. Okay? And again, this is just an example to get you in the mindset of doing that big picture forest down the road type thinking. Okay, so blast lung and of course diffuse axonal injury. Diving right in. So we gave a brief outline of this in the webinar description. We're going to talk about stopping the bleed and stabilizing the patient. And then in addition, we're going to talk about big picture things such as transport, trauma surgery, and training. So starting with stopping the bleed and stabilizing, tourniquets, TXA, abnormal saline, physiologic fluids. Stop the bleed. When it comes to trauma, I cannot emphasize that enough. Often we get stuck on replacing what was lost, and we need to think about physiologic fluids. We need to think about whole blood or whole blood analogs, using ratios to replace and duplicating whole blood with blood products. But the most important thing in any trauma situation is stop the bleed. Right? Keep the little red trucks off the floor and out of the sand, and you won't have to replace them. Common mistakes in terms of point of care, tourniquets. Cannot emphasize it enough. You need to have tourniquets with you. You need to be prepared to improvise tourniquets. You need to conduct training with community health workers on how to improvise tourniquets. Community health workers, an essential link, layperson training. You can't overlook the fact that logistics of transport are one of the biggest factors determining mortality in an austere medicine situation. How long does it take to get the patient to definitive care? And often, the care that they get in the field is the ultimate determination of their long-term mortality. Stopping bleeds and adequate fluid resuscitation in burns are two of the biggest things. Just a couple quick notes on tourniquets. Again, if you need recommendations on specific combat application tourniquets, soft T, etc., we can discuss that offline or in the questions. Main things to remember: you may be conducting, you're not going to be able to hand those out left and right to lay rescuers. So when you're teaching improvising tourniquets, okay, discipline you with a FlipFlop. It's kind of a sociocultural thing depending on your background. Why do you get hit with a FlipFlop instead of a spike heel? The FlipFlop diffuses the pressure over area. It's a relatively harmless thing. When it comes to teaching tourniquets and direct pressure to stop bleeds, we want to teach exactly the opposite: point pressure, point pressure, point pressure. While we're speaking of tourniquets, don't forget another application of tourniquets, envenomation. Know before you go. Prior planning prevents pretty poor performance. What kind of envenomations are you likely to encounter? Is it going to be something that induces a coagulopathy, in which case you don't want to compartmentalize it? Or is it going to be something that's more of a neurotoxin, in which case we often do think about compartmentalizing it? So tourniquets, both trauma and non-trauma applications. Again, remember direct pressure and consider the specific application. Another really good example of force over area would be postpartum hemorrhage in the condom tamponade. The condom tamponade illustrates a lot of very important points for us. We control postpartum hemorrhage in developed nations in level 1 trauma center operating theaters through a variety of devices that you may not have available to you in a remote practice environment. But can you tamponade the uterus with what you have on hand? Absolutely. Condoms make a wonderful uterine tamponade. You're essentially tying the condom off to IV tubing and filling it full of isotonic crystalloid. Okay? And this again allows you to apply direct pressure to an internal cavity. There's many things to think about with tourniquets. The main point of a tourniquet, of course, is to compress against a bony prominence. So you have to think also about those types of injuries where you're not able to do that. You need to think about things like stabilizing long bones, stabilizing pelvic fractures, junctional hemorrhages, places where you can't necessarily apply direct pressure, or injuries in the box or inside a body cavity. Again, postpartum hemorrhage or uterine hemorrhage secondary to trauma would be a great example of not only how to reach that spot and apply pressure, but also of improvising and adapting in a situation where you may not have the most sophisticated tools on hand. And again, know before you go, you need to have done a needs assessment site evaluation before you go and be thinking of these alternative modalities. Speaking of stopping the bleed, TXA. So this is a really great adjunct in austere practice environments where we may have prolonged transport times and difficulty reaching definitive intervention. So it's a lysine analog, prevents clot breakdown, and of course it is on the World Health Organization list of essential medications. And then notice here the generic name for it, the label in French. This brings up another point we'll speak about briefly later, is that be aware that the medications that you have readily on hand, unless you bring them with you, they may not be labeled the way you're used to, or they may not even be the medications that you're used to having. Again, when it comes to austere practice environments and stopping the bleed, TXA, of course, is an invaluable adjunct. There's several studies out there. Of course, the use of this spans over several decades. The MATTERS trials within the military, woman trial for postpartum hemorrhage. Most recently, just in the past 2 weeks, of course, the CRASH trial results were published in Lancet. And then here on this slide, I give you an article directly relating to trauma from the Journal of Emergency Medical Services. Some basic dosing information, again, situationally dependent, but basic guideline for trauma from the Emergency Nursing Association of the United States. Once we have stopped the bleed, replace what was lost. Something to think about, much like TXA, there's a lot of there's a lot of debate, over whether or not TXA is always appropriate. Another big debate in trauma resuscitation is physiologic fluids. I personally am very biased in favor of physiologic fluids. Different trials, different statistics can be interpreted in various ways. Here I list one of the trials for you, SMART, which was just released regarding physiologic fluids and sepsis. I would encourage you to consider unseen endpoints, such as acute kidney injury. Also, replacing what was lost, of course, translates into replacing whole blood or using blood components to give an analog of whole blood. And why is this principle so important of replacing what was lost? Because we're worried about hemodilutional problems. In terms of fluid and electrolytes, we're worried about diluting out essential electrolytes, such as potassium, right? Normal saline doesn't contain potassium, whereas lactated Ringer's lactate Hartmann does. And then, of course, in terms of blood transfusions, we're worried about diluting out clotting factors. And when we dilute these out, right, whether it's electrolytes or clotting factors, we can predispose the patient to dysrhythmias or actually induce coagulopathies. So again, replace what was lost. I can't emphasize it enough. Physiologic fluids and whole blood. Other good adjuncts to think about when we talk about blood products, freeze-dried plasma, Again, some transfusion considerations, as well as sequelae of transfusions, such as TRALI, TACO, TREM, etc. Freeze-dried plasma, I've given you just a brief history of it here, and these principles are very old. People talk about whole blood like it's a new and evolving trend, and it was known back in World War II that we had better results. Our patients who got whole blood did better than patients who got blood components. Freeze-dried plasma has been around for a while. France, Israel, a lot of special operation forces. A lot of research has been done on this. Of course, it's very nice for austere environments because it's compact, it's easy to, logistically, it's easy to transport and maintain. And of course, stopping the bleed. What does a clot consist of? Platelets and clotting factors. That's our #1 rule in trauma, stopping the bleed. Here I mentioned Thor. There's several resources out there dealing with point of care massive hemorrhage. Unfortunately, we learn a lot of these things in times of war. So Thor is another reference for you there that you'll be able to see on the next slide. So trauma, hemostasis, and oxygenation research. Here I put Get Smart, some guidelines and things that you can look at. Forgive me, I have a slight typo there. That should be TCCC, Tactical Combat Casualty Care. That's kind of one of the most basic classes that you can take, and it feeds into the TECC guidelines, Prolonged Field Care Guidelines. There are a lot of classes out there for civilian consumption, and you can take all these classes I just mentioned. Both Thor and PFC are web-based repositories of ongoing research. Please do not think that your civilian classes are adequate. Much like TCCC, they are simply a good place to start. They're good, but they're highly derivative. And you need to stay dynamic. You need to stay abreast of evolving research. You also need to remember that things are taught certain ways for certain practice environments. For example, one of the things that's mentioned in the current ATLS is that we no longer do needle decompression at the 2nd and 3rd midclavicular intercostal. And that's a bit misleading. One of the reasons why it's not a preferred site in certain situations, such as the military, is that you're dealing with people with plate carriers, armored plate over that particular spot. And even if you get the armored plate off under fire, then you're dealing with young men with very large, well-developed pectoral muscles. So the guideline that's recommended under ATLS is 4th and 5th mid-axillary intercostal space, right? 4th and 5th intercostal mid-axillary. Well, that's well and good, but what if your trauma patient happens to be a 3rd trimester female in an austere practice environment where, say, you may not have your ultrasound with you? Well, in that case, the fetus is actually displacing the liver almost directly under the 4th and 5th intercostal space. So I encourage you to take these classes, but again, the slides that we started out with, don't learn facts, understand how to think, understand how to apply them. A given rule or fact may be appropriate in a certain set of circumstances, whereas in humanitarian medicine, you may very well find yourself in different circumstances. For example, that 3rd trimester female with a tension pneumo, 4th and 5th mid-axillary is definitely not the preferred location on the right-hand side. So things to think about, okay? Again, stay fluid with your thinking. In terms of mass transfusion, things that we always need to think about, of course, there's always the risk of sensitizing the immune system or secondary exposure to blood products. Can of course cause an immune-mediated response and reaction. Of course, there's always a risk of infection or exposure to yourself as well as to the patient. The main things that I want to talk about are iatrogenic coagulopathies. There's a few ways that these can happen. #1, excessive blood draws. If you can, use point of care testing, such as ISTAT or EPOC. The other thing to think about, and especially if you're doing frequent labs, the other thing to think about is if you can use pediatric blood volumes in pediatric tubes. That can help preserve your patient's H&H. Also remember that in a lot of these humanitarian environments, you're dealing with patients with baseline anemias from chronic malnutrition or a disease burden such as sickle cell, parasitemia, etc. So you're already dealing with patients who have one strike against them. So do consider your blood volumes for testing very carefully. Some other concepts to think about: pressure, permissive hypotension. In trauma, we say all bleeds stop eventually. It's a rather dark way of looking at it, but basically, essentially, either the patient dies or they clot off. Well, if they clot off, it's typically at a lower than normal blood pressure because they've been bleeding out. So you need to be very careful about aggressively restoring their mean arterial pressure and trying to achieve end organ perfusion, cerebral perfusion pressure right away, because when you introduce a new higher pressure gradient behind that clot that was formed at a low pressure, you run the risk of dislodging it. This isn't as much of a concern when we're talking about extremity hemorrhages and things that can be tamponaded against a long bone with the tourniquet, but it's very much of concern when we're talking about internal bleeds. It doesn't do you any good to get the patient's blood pressure back to a map of 70 if you cause them to dislodge a clot and internally bleed before you can get them, to surgical intervention, to an X-lap or a clamshell, whatever we need to do to find and localize that bleed. So consider permissive hypotension, particularly when you have long transport times. Also consider the patient's comorbidities as well. Obviously, young, healthy patients with the minimum disease burden do better with permissive hypotension strategies. Hemodilution, I mentioned earlier. Of course, this is one of the main reasons why we want to give whole blood or duplicate whole blood by giving blood components in a ratio. If you just replace oxygen delivery capacity by transfusing packed red cells, in a mass transfusion situation, you run the risk of hemodiluting out platelets and clotting factors and actually inducing a coagulopathy. When we talk about ratios, there's various data out there, but one consensus guideline is to do a 1-to-1-to-1. One of red, one of packed red cells, one of clotting factors, one of platelets, until you can obtain and trend clotting times, and then adjust your blood components accordingly. Another very important thing to keep in mind in terms of iatrogenic coagulopathies is that our blood components, even whole blood, are preserved using chemicals that chelate or bind calcium. So when you're transfusing large amounts of these products, you run the risk of inducing a hypocalcemia in your patient. And the problem with that is that you need calcium to form clots. So if you're giving large amounts of banked blood, keep in mind the need to monitor the patient's ionized calcium and consider the need to possibly replace it. Another strategy I would mention here, it's not on the slide, but never lose sight of the fact that typing and crossing blood is fairly easy to do in the field, and there's always the possibility of collecting blood, transfusing from donors on site, and not just being dependent upon banked blood. That's one strategy that's used in special operations where your battle buddy is matched to your blood type, and you are both trained on how to transfuse each other. So another thing to think about there. A few other points outside of coagulopathies. Do remember that banked blood does contain a certain amount of hemolyzed cells. So transfusion of large amounts of banked blood can actually result in a hyperkalemia, because when those cells die, of course, they release potassium. So you may need to consider the need for that, especially if your patient has pre-existing renal comorbidities or they have acute kidney injury from prolonged blood loss. They have a pre-renal acute kidney injury. So consider the need to monitor for hyperkalemia and treat accordingly. And then, of course, be aware of long-term sequelae, long meaning, not during the transfusion, but shortly thereafter, such as transfusion-related acute lung injury, other autoimmune mediated responses such as circulation overload, hemolysis, etc. Okay, so a few quick clinical pearls there about transfusing blood products. Don't forget the basics, trauma triad of death. So acidosis, hypothermia, and coagulopathy feed into each other in a great downward spiral. This is why one of the most basic things that you can teach people in terms of shock management is to keep the patient warm. Okay? So here, just displaying that trauma triad of death for you. Always take that into account. Field amputations. Again, we're only speaking for about 45 minutes here, so we can't go into detail, but I can't emphasize enough that when you're responding to a situation, like say the earthquake in Haiti, that there may very well be a need for field amputation. So plan accordingly, life before limb. That was a very common surgery performed immediately after the Haiti earthquake. So think about things like earthquakes, bomb blasts, etc. The need for field amputation. Prior planning prevents pretty poor performance, so please plan accordingly. Another thing I cannot emphasize enough that is very frequently overlooked is amnesia and analgesia. Please consider multimodal strategies. In our next slide, I'll show you the 4 parts of the pain pathway. But an essential part of austere medicine is the use of locals and regionals. You can guide those with point of care ultrasound, POCUS, but there are also techniques, of course, using anatomical landmarks. If you are in such an austere environment that you don't have your personal ultrasound machine. And when I say personal ultrasound machine, please don't think that that's an unrealistic expectation. I own a personal ultrasound machine. They're on the market now for under $3,000, and mine is about the size of an iPad with the probe included. So very realistic to expect that you would have point of care ultrasound, both to guide your trauma assessment as well as things like placing regionals. Here I give you a free resource, the Military Advanced Regional Anesthesia and Analgesia Handbook. If you just Google that, it'll pop right up. I cannot emphasize enough, this is something that you really need to get smart on, and you may or may not have an anesthetist with you. Okay? You're going to have a limited supply of medicines. When we talk about triage, who gets what, this is one way that you can conserve your medication is through using nerve blocks. Okay? So a quick thing for you to take into consideration. When you look at pain management, pain pathway has 4 major parts. Transduction, converting the painful stimuli into a nervous signal. Modulation, transmission, right, to the spinal cord up your efferent fibers. Modulation inside the spinal cord through your alpha, delta, Charlie fibers. And then, of course, up and down the spinothalamic tract, going through the hypothalamus, thalamus, hypothalamus, and of course, ultimately up to the sensory cortex. Each one of these places, transduction, transmission, perception, and the cortex, are affected by different pain medications. This is a classic diagram showing you what medications are most effective. And in an austere practice environment, I would strongly urge you to consider the use of NSAIDs and peripheral nerve blocks. Why are NSAIDs so essential? Well, when we talk about trauma, we're talking about musculoskeletal injuries. And you can never, never, ever, never forget your basic biology and physiology. When you look at the neurotransmitters involved in musculoskeletal injuries, what are they? Prostaglandins. So I'm sure many of you have heard of COX-1, COX-2, the cyclooxygenase pathways. NSAIDs interact with those pathways to stop the production of prostaglandin. You're literally stopping the pain. Peripheral nerve blocks then stop the transmission of that signal up the spinothalamic tracts to the sensory cortex. We have developed dependence as healthcare providers on opioids and PO opioids. Bear in mind that the primary action of opioids, especially PO opioids, is on perception. Opioids don't actually make you hurt less, they make you care less that you're hurting. So please don't neglect the basic physiology and basic medications such as NSAIDs and again, nerve blocks. Okay, can't emphasize that enough. Speaking of medications, prior planning prevents pretty poor performance. How are you going to get your medications in? Some techniques that we don't use as often as we could in developed countries. Consider things such as interosseous, intramuscular, intranasal. I can't emphasize those techniques enough. So many times you are in places where it is very difficult to get IV access and just forget about central line access. Lots of luck with sterile conditions and things like that. I cannot emphasize enough the importance of interosseous, intramuscular, and intranasal routes. Again, the earthquake after Haiti was a prime example of this. The gentleman that invented the EZ-IO was in Haiti after the earthquake. Okay? The nice thing about interosseous, bones don't collapse, right? So your patient's volume status doesn't matter. Okay? So interosseous, intramuscular, intranasal, don't forget those. Plan ahead. Make sure you have that sort of equipment. Keep it in your back pocket. Pressure bags. Why do I say pressure bags? Again, it comes back to prior planning. What sort of power are you going to have? Are you going to be able to power pumps? Are you even going to have pumps to use? Pressure bags. Think about pressure bags. And I say real, please carry a bunch with you. But can we improvise pressure bags? Absolutely. Two of the easiest ways to improvise pressure bags, use a blood pressure cuff. That makes a great pressure bag. Another thing you can do, of course, is actually pump air into your bag or your bottles, your plastic bottles of IV fluids, and use the air to create a pressure differential so that you can run the fluid in quickly. So can't emphasize enough, these are the kind of forest items that get overlooked when people are narrowly focusing on their specific skill set. They say, oh, well, we're just going to do this. And they're so used to doing it in a practice environment where they have everything at their disposal. Sometimes something as simple as getting an IV can be tremendously complex when you're talking about austere practice environments. So a few things for your consideration there. As I mentioned earlier with TXA, think about the fact that your drugs may have alternative labeling. The labeling may be in a language that you're not familiar with. Think about the fact that you may not have the drugs you're familiar with. For example, traumatic brain injury, we referred to that earlier. Osmotic diuresis, you're not going to find a lot of 3% in remote practice environments. But what you will find a lot of is sodium bicarb. And sodium bicarb is 6%. So you can dilute it out and use it, of course, with the appropriate caveats that you're going to have some pH issues, etc. Improvise, adapt, and overcome. You may not have the drugs that you're used to for analgesia, amnesia, sedatives. Thiopental would be one example. I've seen thiopental used very many times in austere practice environments, and yet it's in museums in the United States, for example. Needle decompression, chest tubes. I have seen many improvs with these. Things to think about. Think about your common surgical procedures. Monitors. You're not going to have monitors. Two of my most common monitors that I use, pulse oximeters. For $25, you can buy a pulse oximeter that does heart tones in addition to SATs and has a pleth on it. That's a hemodynamic waveform. And that pulse oximeter will let you set high and low alarms for both SATs and heart rate. So I can see rate, I can see regularity, I can see how my patient's satting. $25 ICU monitor in your pocket. I'm still carrying a pulse oximeter that I bought for $25 that I ran over it with the Toyota Land Cruiser in a jungle in Liberia. Takes a licking, keeps on ticking. Okay, don't overlook simple things. End-tidal CO2. I carry an end-tidal CO2 monitor with me often for post-operative monitoring, because under the right circumstances, in an intubated patient, it basically equates to a cardiac output monitor. So every 10 of CO2 roughly equals 1 liter of cardiac output. So think about the fact that you're not going to have the usual equipment in terms of peri and post-operative monitoring, and ask yourself, begin with the end in mind, ask yourself, how can you adapt and overcome that? Never lose sight of the basics in terms of physiology. When we talk about basic shock management, remember, perfusion is always the right answer. When we talk about perfusion, we're talking about end organ perfusion, cerebral perfusion pressure. Why is that so important? Very simple. The brain's the only organ that can't be replaced with donated tissue, a machine, or pharmacology. So when we're talking about hemorrhagic shock, the right answer is always perfuse the brain. How are you going to perfuse the brain? By optimizing cardiac output. Every variable we've discussed so far, and variables we will discuss, it all comes down to stroke volume. It all comes down to contractility. Okay, we want to keep the patient warm, thermoregulated. We want to keep them pink, oxygenated. Sweet, we need to feed them. If they're NPO, we need to think about dextrose for our IV fluids, our electrolytes, and our hemodilutional dyscrasias, acidosis, temperature, glucose. Don't take your eyes off the prize. Remember, your goal is end organ perfusion. How are you going to achieve it? Optimizing components of cardiac output, particularly stroke volume. Moving on to, that was stabilization. Moving on to transport, trauma surgery training, triage, transport, telemedicine, therapy, building capacity in trauma systems where there are none. So again, some broad brushstroke important considerations for you. Triage, not only often, for example, if you take ICU personnel with you, they're not trained in triage. You need to do triage for your staff as well as for locals. Often that triage also devolves down to the fact that you are truly in a mass casualty situation and you are trying to do the greatest good for the greatest number. So allocation of resources. Okay? I can't tell you how many times I have found myself without enough medication or without the proper equipment and have had to make hard decisions about which patients are most likely to have the best outcomes and which patients, we're going to have to put it in the hands of the gods and hope that they pull through. So triage, triage, triage. Have a system in place. Know before you go so that those hard decisions are a little bit easier for you. They're never easy, but thinking about it ahead of time, pre-gaming it, can help you and your patients quite a bit. It's also very important when we're training our community health workers so that they understand which patients need to be transported versus which patients can stay and play for a little while. Load and go versus stay and play. Speaking of loading and going, the the places that I'm thinking of in my head, most of them do not have well-developed EMS or ambulance services. So you're likely to be dealing with something like moto taxis. The one on the right, of course, is a historical diagram of a field transport, military field transport. But the one on the left is in current use in southern Sudan. Another great example of this is Israel. Israel has a highly developed moped trauma treatment, stabilization, transport system in place. Many countries do. We do not do it so much in the US. Little bit in Europe, depending on where you're at in Europe, and even then, it's more that they're using the motorcycles to stabilize the patients at the point of injury versus transport. So think about how you're going to get your patient from point of injury to definitive intervention. Often motos are the answer. Telemedicine devices and applications, etc. We could do an entire lecture on this. In fact, I've actually done many lectures on this, both for Wadham and other people. It's sort of a niche specialization of mine. So I'm just going to mention a few broad considerations here. There's many devices out there. There's many apps out there. Always consider your power requirements. Can you run this thing off of solar, for example? Can you run it off of batteries that you've charged with solar? Cannot emphasize enough, think about bandwidth requirements, bandwidth requirements, bandwidth requirements. All the fancy equipment in the world's not going to do you any good if you can't get a signal to get your information in and out on. Okay? We can use telemedicine for a variety of things, to conduct training, consulting, perioperative intervention, EMS. Here I give you an example of an emergency medical system telemedicine app, the Beacon app, which helps mobilize community health workers, ambulance services in resource-limited environments. That's put out by TREC. Again, just one example. We could easily fill an entire hour just talking about devices or just talking about apps. But just because something's shiny doesn't mean it's good. Ask yourself about your power and bandwidth requirements. Ask yourself about your specific applications. Are you using it to conduct training so that you're pre-gaming before the trauma hits? Are you using it for a perioperative consult? Take those factors into account when you're selecting your devices and your apps. Training. Can't emphasize training enough. There are many trauma classes and triage classes and things out there, not only to make yourself familiar with, but especially the host nation that you're going to be interacting with. Again, helping community health workers and lay people understand which patients need immediate transport is essential. So there's many classes out there. I list a couple here. I don't use either of the two classes I listed there extensively because, of course, I've developed my own coursework that's kind of a hybrid of various things, and it always adapts to where I'm at. Different countries have different needs. The course that I teach, I kind of joke and say it's burns, breaks, bleeds, and babies, because what are common trauma and blood loss? When you're looking at remote austere practice environments, often maternal newborn mortality is incredibly high due to hemorrhage. So I will often teach classes that revolve around proper fluid resuscitation in burns, how to stabilize long bone fractures, how to tamponade external bleeds, proper improvised tourniquet techniques, and of course techniques recognizing an early transport and intervention in postpartum hemorrhage. So again, like I cautioned you before with the out-of-the-box classes such as Trauma Nursing Core Curriculum or ATLS, the name of the game when you're talking about remote medicine is don't get stuck on a static picture of a dynamic situation. Be prepared to adapt and overcome. All of these things are wonderful starting points, but be sure to adapt them to your particular practice environment as well as to the socio-cultural needs of those you're interacting with. I can't emphasize where there is no doctor enough. It actually forms a large part of my burns, breaks, bleeds, and babies class. And the reason why is that this book is published in many, many languages. So I simply take the chapter on trauma, and you're welcome to reproduce these things. Hesperian allows you to, but I also spend quite a bit of money with this company every year so that I can give handouts in the native languages. The other thing to think about is functional literacy. Where there is no doctor, almost every single intervention is displayed with both pictures and words. So it helps address multiple levels of literacy within your target population. So I can't emphasize that enough. This is a great resource when you're teaching trauma management for community health workers and lay rescuers. Teaching yourself. Cultural competency, understanding different people learn different ways in different environments, different cultures. Helping health workers learn. This is a great way to teach yourself how to teach community health workers. Again, helping health workers learn. I see many, many well-intentioned medical mission workers who are profoundly ignorant of whether or not they're actually getting through to their target audience because they're doing canned, pre-scripted courses that may not have been adapted to their particular environment that they're trying to practice in. Studying this book ahead of time can help make you aware of many of those issues and make you a much better educator and a much better practitioner. This book is a personal favorite of mine, War Surgery. It's a great look at adapting and overcoming, improvising in austere and remote practice environments, particularly with respect to trauma surgery. I can't emphasize it enough. If you think that you're going to find yourself in that sort of environment, this would be a good reference for you. In terms of sociocultural competency, many books out there. I don't particularly recommend this one over any others, but do take time to educate yourself. Paul Farmer has a great book about his experiences in Haiti, etc., etc. Many people want to run in and play Johnny Rescue, Mother Teresa, and law of unintended consequences. So please try and educate yourself ahead of time, not only about the needs of the medicine that you're going to be performing, but also the sociocultural milieu that you're going to be performing that medicine in. Okay? Moving on, training. Point of care ultrasound. As I mentioned, I'm a little biased. I've been rocking the point of care ultrasound for many years through many different devices, Clarius, Butterfly, Philips, etc., etc. For austere environments, point of care ultrasound is an invaluable adjunct in both medical and trauma patients. And not only should you be taking it with you, but you should be looking at the possibilities of donating equipment and training. I'm currently trying to set up a program at a remote hospital in Haiti. Why? Because x-rays are almost impossible to get, and you can forget about MRI or CT scan. That's a multiple hour transport across mountains and through some unsafe areas. Okay? So point of care ultrasound, not only can we use it for regional anesthesia, like I pointed out before, and pain management, but also many advantages over other imaging modalities. So great return on investment, ROI, with point of care ultrasound. If you're considering what sort of training, trauma training you can do to make a difference, consider point of care ultrasound. It can make a huge difference in ramping up and capacity building in many remote environments. Some other applications and things to think about medical records, think about follow-up care. I give you two things kind of at opposite ends of the spectrum here. Open MRS, which is meant for more of like local hospital systems. And then FEMUR, which is meant more for short-term medical missions, but allowing you to do handoff with groups that come behind you with regards to the patients that you have taken care of. Speaking of handoff and groups that come behind you, if we're talking trauma, often we need to think about post-op follow-up. Most of our missions are time limited in nature, so who's coming behind us? Don't forget that many of these patients will need prosthetics, they will need physical therapy, they will need occupational therapy. I can't emphasize enough how important it is to consider partnering with other medical mission groups, that sort of therapy is their primary goal, especially if developing capacity for that sort of therapy is their primary goal. Again, I display one group here that I've had the pleasure to collaborate with in Haiti, STAND, and they've done incredible things for trauma patients in Haiti. So remember, it's not just about stopping the bleed, it's about what comes after the operation as well. Psychosocial considerations, not just physical health, but mental health, okay? And this is both for the patients and for you. Here I mention a few things. The World Health Organization has great guidelines, both for pre-deployment as well as during the deployment. Other things to think about, critical incident stress debriefing. I'm actually really glad that Dr. Common is doing his webinar a few weeks after this one, because mental health is very, very commonly overlooked. You are going to see things that will haunt you for the rest of your life. Your patients are going to experience things that will haunt them for the rest of their life. I literally went and worked in the hot zone during the last Ebola outbreak as a mental health break, relative to a lot of the things that I was seeing and dealing with in Haiti. So this is another begin with the end in mind, and recognize that we're not just taking care of the body, but also the mind and soul, and not just your body, but your patient's minds and souls. Okay? Here I just give you a few quick slides on critical incident stress debriefing. I'm not going to go into them in detail, especially as I know Dr. Common will be following me in a few weeks with a much more in-depth analysis. So they're here for your reference. Okay? And these are things that can also, I put critical incident stress debriefing here because it often needs to take place peri-mission. I have seen humanitarians literally incapacitated mid-mission by some of the things that they've had to do or experience. So that's why I chose to include these 3 slides for you. Okay? Again, pre-game your mental health game. That brings the webinar to a conclusion. As far as contacting me, email, social media, as Andrew, I'll give you my Facebook page here in a moment. As Andrew said, save the date, 11th through the 14th of May in Tokyo, Japan. I gave you my email in one of the introductory slides. If you'd like to reach out to me on Facebook, please feel free. Facebook, that's an interesting thing. Why do I have Facebook in a lecture on austere medicine? Well, in many low and middle income countries, social media is free. So I do telemedicine over Facebook and WhatsApp all the time because it would cost them money to send me the patient records via email, and it would use data that they don't have. So consider social media as a telemedicine app. Also consider, when you're thinking about how you can help, often having dedicated funds for phone bills for the people that you're liaising with in country is invaluable. So again, I'm giving you Facebook here so that you can contact me, but please don't overlook social media as a way of conducting telemedicine either. It's something I do quite often. And with that, we will open it up. If you have any questions, comments, concerns, again, thank you very much for having me, and thank you for taking time out of your day to listen. If you have any questions, please feel free to ask.
Thank you, Sean, for a really well-organized and exhaustive presentation there. You got through about 50 slides. I'm really impressed. So now we're at the point in the presentation where the remote audience can ask questions, and we can actually unmute your microphone and you can ask a question directly to Sean. That's the preferred way to do it because often a question leads to a follow-up question. If you're feeling a bit shy and don't want to do that, you can also send me a question and I can read it out loud. So at this stage, we're leaving it up to you guys in the remote audience to come forth with any questions you may have.
Wow, we've got a lot of shy people.
Well, this happens from time to time. I have a question for you, Sean. Regarding like preparing someone sort of, you went through a lot of the information about actually performing, providing medical care in an austere environment. How do you suggest preparing someone culturally, or just getting them knowledgeable on the situation they're going to face on the ground, whether it's culture, politics, economic
Sure.
issues.
Sure, and you actually indirectly brought up something that I neglected when I was making plugs for conferences and things like that. This is tangential to your question, and I'll bring it back around. But allow me to make a plug for IPRED. It's a conference in Israel by our colleagues in Israel. And why am I bringing that up relative to preparation? Because every conference they do a wonderful mass casualty exercise showing these types of injuries, the patient flow through the trauma system, the command and control, the telecommunications. So going to something like IPRED that does a integrated mass casualty exercise, it's invaluable training. You're not going to get that sort of training strictly through doing disaster prep classes. So I would highly recommend a conference such as IPRED to get you in an overall mindset. And then as far as a specific country mindset, there are many sources of information. The CDC is great for travel and tropical medicine, Center for Disease Control, the Yellow Book. They also have very extensive country briefs for healthcare providers. In terms of political, social unrest, things like that. The U.S. State Department maintains several websites, as well as the CIA Fact Book. Those are both great ways to get good backgrounders. I cannot emphasize enough, talk to locals, talk to locals, talk to locals. Secondhand information is better than nothing. But we have a saying in the military, don't second guess the guy on the ground. So if you really want to get smart, you need to make sure that you're working with locals and use their advice and tell them, be humble. Say that you're, I say that everywhere I go. It's almost always the first words out of my mouth. They're like, oh, you're here to teach us ultrasound or vent management. No, I'm here to learn from you. I have a tiny little skill here that I'm going to teach you, but I'm helpless and useless without you. I need you to help me learn how to help you. I need you to teach me, and I need you to critique me and be honest and help me understand, how I can best interact within your socio-cultural milieu. And you would be surprised at the things, that you learn talking to locals that, of course, you would never get out of a State Department briefing. So did that answer your question, Andrew?
Yeah, so I guess what you're saying is essentially one ought to do their homework prior to going, which I know you mentioned a number of times during the presentation, that it's really incumbent on someone who's going to, say, do a medical mission abroad, that they put the time and research in to have a relatively good understanding of what they're going to be facing on the ground in terms of culture, economics, resources, politics, infrastructure, etc.
Absolutely. And and again, we could do a week's worth of webinars on that sort of thing. One broad brushstroke thing to remember, it's, an old rule of etiquette, gentlemen don't discuss religion or politics. That's a good thing to keep in mind with your medical mission work. So in terms of how to not get into trouble with the locals. But yeah, so definitely multiple things we could look at there. Absolutely. What else have we got?
I think we have a very shy group here. Maybe it's Friday and everyone's ready for the weekend. Just to reiterate, you can click on that hand icon, which is essentially the equivalent of you virtually raising your hand. We can unmute your microphone and you can ask a question directly to Sean. You can also send a question to me and I'll ask it.
And of course, I gave you my personal Facebook page as well as my email address, so you're more than welcome to hit me up after the fact. Often when you attend something like this or an educational event, if you're anything like me, I often come up with many questions after the information's had time to percolate. Like you may have more specific questions about Andrew's last question, you know, how you can best prepare yourself, what sort of pre-gaming and homework do you need to do. So again, please don't hesitate to look me up on social media or to email me. It's no trouble at all. My life basically revolves around my medical mission work, and I'm delighted to help any and everyone become a more effective humanitarian. So please don't hesitate to reach out.
Okay, we have a question from Andre. I'm gonna put you on the spot and unmute your microphone. And could you ask your question directly to Sean? You there, Andre? Okay, well, he sent it in by text, so I thought I'd put him on the spot. He says, hello, Sean. Thank you for this very good presentation. I would like to ask, in a context of trauma in a remote area where I have no anesthesia, what do you use to protect from pain?
Yes, and I would strongly encourage you to get smart on nerve blocks and NSAIDs. When we're talking trauma, we're talking musculoskeletal pain. NSAIDs are very low cost, non-steroidal anti-inflammatories, very low cost on the World Health Organization essential medications list. So a combination of NSAIDs and nerve blocks goes a long ways. And in fact, that's a mainstay of our pain management from a military perspective in remote and austere practice environments. So nerve blocks, NSAIDs, can't emphasize them enough. What else have we got? And again, please, if I don't answer a question to the degree that you would like me to, please don't hesitate to reach out offline. But I did provide a reference there for a free textbook on peripheral nerve blocks, the military regional anesthesia textbook, Mara.
Well, we don't have any more questions, so I think at this stage, oh, of course, here we get one right when I say that.
No worries.
We have a question here from Sarah Hopfer. It says, hi, Sean. Thanks for the presentation. Could you say a little bit more about the logistics of running medical equipment in austere environments? For example, POCUS is only good until your battery runs out.
Exactly, and that's why I made the point about making sure that you understand what your power supplies are. I would highly advise you to research what kind of converters you need. Consider if your mission's large enough, consider pre-purchasing fuel, consider bringing generators with you or purchasing generators in country. Consider solar power. You say that your ultrasound's only good until your battery runs out, but there's many solar panel power supplies to charge batteries, and your ultrasound won't die on you if you take things like that into account. And it's important to ration your power supplies. So use solar when the sun shines and when you can charge your batteries so that when the sun's not shining, you've got batteries. Use fuel when you absolutely have to. If you're using local power, please, please, please remember that no matter where you're at, the local power is almost always what we call dirty, where the frequency and the surges aren't tightly regulated. I have seen so much medical mission equipment get turned into paperweights by being damaged by power surges. So key points, make sure that you have your converters, make sure you have surge protectors, make sure you have backups to the backups to the backups, that you've pre-purchased fuel, that you have your own generators. Generators are like currency in foreign countries. Keep them under lock and key. They grow legs, they get stolen, etc. Fuel and generators both need to be, literally guarded. Consider solar. Use solar as much as you can, both for small devices like point of care ultrasound, as well as big picture things like facility lighting. So absolutely, I cannot emphasize pre-gaming your power supply and having backups to the backups. That is essential for doing trauma in remote environments.
Thank you, Sarah, for asking that question. Well, I think we are now at the point, of course, right when I say that, another one. Well, that's great. I have nowhere to go, so I'm happy staying on.
My life is devoted to this, so I will stay on as well.
All right, so we have a question here from Justin Bays, and Justin asks, what are some of the most high demand medical and medical support positions on medical missions?
I would say anesthesia, definitely. I've seen missions be canceled for lack of anesthesia. So that's essential. Definitely need to consider post-op monitoring because especially on medical missions, your surgeons are doing surgery nonstop, and they're just swapping out with each other. If they're not cutting and suturing, they're sleeping. So post-op monitoring of patients, particularly blood loss, anastomosis, quality, things like that. And definitely in the perioperative environment, anesthesia, anesthesia, anesthesia. And don't overlook the whole point of this lecture: logistics, logistics, logistics. Good logistics can make or break a mission. So, people always focus on medical skills. Don't forget good business skills and good logistics, that big picture. That's why I started off with that slide saying, when people think medical mission work, they think medical, and they miss the forest for the trees. Medical can't function without logistical support. So being good at supply chain things, knowing how to source things locally, knowing how to get things through customs, that sort of thing is huge. I've also seen medical missions get held up because equipment and supplies were held up in customs, or because people assumed they could get things on the ground in country, not realizing the difficulties involved. So post-op monitoring, perioperative anesthesia, and pre-gaming, logistics, logistics, logistics. I would say those are three pillars of successful trauma management in austere environments. And don't forget education and training. Sorry, I said three, there's four, at least four. Because again, it's not just about your short-term mission, it's about leaving it better than you found it. And education and training is definitely a skill set unto itself that often people overlook. They think, oh, I can perform this surgery or I have this skill set. That doesn't always translate into being an effective teacher. So being effective at logistics, being an effective teacher, try and broaden your skill set as much as you can, because medical mission work is very rarely all about the specialty. It's about generalists, people who are synergistic. They can put 2 and 2 together and get 7, people who can adapt and overcome. So try to have a broad base of education, broad skill sets, consider languages, consider education, consider logistics, and do not forget anesthesia and pain management. And I've referred to it in the perioperative environment, but of course post-op or in emergency medicine. Can we do nerve blocks? Absolutely. So there's a whole handful of essential skill sets for you. And if that's not enough, keep the questions coming or hit me up offline. But those are some of the most important in my book.
Thank you, Justin, for that question. And Justin just had a follow-up comment. Thank you, Mr. Smith. Excellent presentation.
And thank you for attending, sir. I appreciate you.
I have a question, Sean, now that you bring up logistics, and a lot of your presentation is about providing care and working in a resource poor environment. When you're on one of these medical missions or just in general working in these situations, how do you stay healthy? Like I guess even like where do you stay? Are you staying near where you're providing care? Are you in tents typically? I would imagine you're not going back to a hotel very often and having a hot shower and some of the amenities that we'd usually be used to. Like, are you pretty much roughing it out there?
Sure. Yeah, it all depends on the environment and where you find yourself. I used to live on the roof of a hospital in Haiti, for example. A local hospital. It all depends on where you find yourself. And that's another key thing too. Learn how to pack light, learn how to use, when we were talking earlier about the CDC, make sure you get your vaccinations, make sure you carry an appropriate array of personal medications for yourself. I carry a wide variety of anti-malarials, antibiotics, pain meds, etc. Don't neglect mental health. Make sure that you find some time for yourself every day during the mission. Don't neglect physical health, even if it's only 10 minutes of calisthenic circuit training. Healthy body, healthy mind. In terms of diet, general travel rules apply. Eat things that have been thoroughly cooked. Eat things that you can peel. Be careful of street food. Be careful of water. I usually carry multiple water purification systems with me, a combination of both filters and chemical purification systems. I boil things a lot. When we talk about self-care, it's really multifactorial. But those are the types of things that you need to pay attention to: healthy mind, healthy body, and keeping yourself healthy while you're there, regardless of the circumstances that you find yourself in. Don't forget things like mosquito netting, right? That's a very commonly overlooked thing. So yeah, absolutely. That could be a week's worth of webinars in and of itself. And again, a lot of it depends on where you find yourself. Absolutely. So thanks for that question, Andrew. That's always a great question. And as you said, you have, I've been with Wadham for a few years now, and you've seen a lot of my lectures and material, and that's a very common reoccurring theme. Is again, people get focused on their specific skill set because they've never had to think about all of these ancillary things in their home nation. As far as how to, what vaccinations to get, how to get clean water, how to stay warm, how to stay dry, those sorts of things. So that's always a question well worth asking. So thank you very much for asking it.
Well, I do think now we have no further questions. So I want to thank Sean for doing this presentation for Wadham. As I mentioned at the beginning, this is the third webinar he's done for us, so we're really appreciative of him taking the time to do these and sharing his expertise with everyone. And I'll just make one last plug, and thank you, Sean, for also bringing this up. The next webinar will be on November 7th, Thursday, November 7th at 11 a.m. Eastern time. So it'll start 30 minutes earlier than this webinar. And it's the presenter is Dr. Richard Kamen, and he's from University of Connecticut, UConn Health, and he will be giving a presentation titled Acute Stress, a Normal Response to an Abnormal Event. And I think it'll touch a lot on some of the psychosocial issues and mental health issues that Sean brought up briefly towards the end of his presentation. So I think there'll be actually a nice segue between this presentation and the next webinar that we have. So I'll include a link in there and some information with the information about the webinar going, or the recording being posted online. We'll make the slides available, and we'll also provide Sean's email address and link to his Facebook page so you can reach out to him with any questions that come up post presentation here. So with that, Sean, again, I really like to thank you for doing this. We're very appreciative of it. I can't say it enough. We rely so heavily on volunteers to do this for us. And so thank you.
No worries. Thank you so much for having me. I know it takes a lot of logistics work to make something like this happen. So I appreciate you being the magic behind the scene. So thank you very much.
And thank you to everyone in the remote audience. I know depending where you are, it's morning, noon, night. It might even be Saturday already. And so thank you, and everyone have a great weekend, and we'll let you know by email when everything is posted online.
Right. Sounds good. Sayonara. Hasta la pasta. Talk to everyone soon.